back and forth. However, doing this over Zoom can be a bit tricky. So I'm going to ask that we just do that at the end, our Q&A, instead of doing throughout the presentation. And then we can talk and I ask for challenges, discussions, questions, clarifying points, any of that stuff. I'm happy to have those types of conversations throughout there. So let's get started. So first, let me just introduce myself for those who may not know me. I am Dr. Dante Bernard. I used to be sitting in the seats just like you all as a grad student at UNC. I'm currently a faculty member at the Medical University of South Carolina, but in about 2 weeks, I'll be transitioning to the University of Missouri as an assistant professor there. As was shared in a gracious introduction, my program of research broadly seeks to understand the association between racism and various mental health outcomes and the risk and resilience processes that shape how youth negotiate these experiences. So this goal is guided by 3 specific aims. So first, I'm interested in expanding knowledge as to the association between racism-related stress and mental health outcomes to incorporate considerations of traumatic stress sequelae, and for those of you who followed some of my grad school work, well-being indicators such as the imposter phenomenon or imposter syndrome across sensitive developmental periods. Second, I'm committed to understanding or investigating the interplay between culturally relevant risk and protective factors. So for example, I'm interested in understanding the buffering effects of racial identity on the link between racial discrimination and health outcomes. And third, as a science practitioner, I'm interested in elucidating culturally relevant pathways of risk and resilience that link or disrupt the connection between racism and health outcomes in efforts to finding avenues to preventing negative mental health outcomes and promoting positive ones. Today, I'll be sharing some topics that talk about the first and third kind of aim of my research, but I'm sure throughout the discussion, we'll talk about several aims here. But I also share this to say that as a grad student, I wasn't really sure where I was going with my work, right? I knew that I was interested in racism broadly and imposter work broadly, but as I've continued this work, I think these domains have really been fleshed out, and I'm excited to be able to talk with you about kind of my trajectory or kind of how this thing kind of came to fruition. So for today's talk, I'll be briefly reviewing the significance of childhood trauma. I'll introduce the adverse childhood experiences framework, discuss the significance of racism and racial discrimination and why we need to consider that within this framework, share some recent research that I've discussed or put forth, and then we'll end with some Q&A and discussion points. So to begin, what we know is that there's overwhelming evidence documenting that trauma represents a significant risk to the health of children, right? Unfortunately, trauma exposure is common, with youth endorsing at least one experience before the age of 16. And if we broaden that out, we find that 50% of youth are going to experience experiences before the age of 18. Unfortunately, however, literature has documented that significant disparities exist when we think about trauma exposure. Specifically, we find that Black youth in particular are disproportionately burdened by these experiences. And the question is why? Well, what's putting these communities of this population at greater risk? Research finds that Black youth are overrepresented in contexts where trauma exposure is more likely to occur, such as low-income communities, juvenile detention centers, foster care placements. And these disparities in trauma exposure don't exist by coincidence, right? But rather the product of these inequitable social systems shaped by racism and discrimination, which I'll be talking about today. Before we talk about racism and discrimination, it's important to position how I conceptualize and think about traumatic stress. Several theoretical frameworks have been put forth to highlight the increased risk conferred by trauma, with the adverse childhood experiences or ACEs framework representing perhaps one of the most popular among them. According to this model, adverse childhood experiences can play a fundamental role in the development and can increase risk for educational, psychological, and educational health concerns across the life course, particularly through its effects on social impairment, the adoption of health risk behaviors, and the early onset of disease, disabilities, and social problems. ACEs can take many forms, and in the literature are broadly defined as any individual or environmental experience that disrupts the child's sense of safety, stability, or bonding. Despite that broad definition, though, the literature tends to focus on these 10, right, that kind of fall under this umbrella of abuse, neglect, and household dysfunction. By and large, if you look at the literature, you'll find some different configuration of these. Give or take a few might be added, but these are kind of the core or conventional ACEs that they consider in the literature that they talk about. The ACEs model purports that ACEs have a dose-dependent effect on health. Said differently, as the number of these adverse childhood experiences happen before the age of 18, so too does the risk for illness, disease, and social problems across the life course. So the accumulation of these ACEs have been linked to a host of negative health outcomes across the life course, right? Including negative mental health concerns such as PTSD, substance use and alcohol abuse, cardiovascular concerns, and even early death. And according to the National Survey of Children's Health, nearly 50% of all children have experienced at least one ACE within the United States. Alarmingly, however, when we disaggregate this data, we find that Black youth are more than 10% more likely to report 3 to 4 ACEs compared to their white peers who tend to be on that lower side. So again, if we think about adverse childhood experiences being associated with these negative health outcomes, and that's just with one, what we find is that as we think about the accumulation of ACEs, the outcomes become more stark, right? Become more concerning, right? So we have adverse childhood experiences being associated with later life suicide. We have adverse childhood experiences being associated with accelerated aging, such that we find that youth are developing their molars at earlier ages as the number of ACEs increase. We also find that ACEs are associated with infant mortality, infant health concerns, and also infant maltreatment. We also find that ACEs are associated with these mental health and chronic health conditions as youth get older. So said differently, ACEs are bad for health across the board, right? And as I shared, about 50% of youth across the US experience at least one ACE. And drawing from data collected by the Behavioral Risk Factor Surveillance System, we find that ACEs within North Carolina kind of by and large fit that same pattern. We have about 50%, give or take 5% or so, in North Carolina are reporting one or more ACEs relative to folks who are not. Some would say, yes, this is great. This is great data that we have. The majority of youth are not experiencing any ACEs, fantastic. However, this is not the full picture. In fact, if we kind of disaggregate this data, so who is experiencing multiple ACEs, what we find, and I recognize it's a busy map here, but just pay attention to this 36% and 37%. What we're finding here is that youth of color are reporting 2 or more ACEs at significantly higher rates than that of their white counterparts. Further, what we find is that folks in poverty are significantly more likely to report multiple ACEs relative to that of their white counterpart, of their more affluent counterparts. This begs the question, who is most likely to be in poverty? Who is most likely to experience these concerns? What we know in the literature is that Black and brown youth are disproportionately embedded within these spaces, meaning that they are overrepresented in the folks who are experiencing these adverse childhood experiences. What North Carolina is saying is that, look, we recognize that there's about 23% of folks reporting at least 2 or more. That's a problem. What we hope to do by 2030 is to reduce that to get to about 18%. However, that still leaves Black and brown families disproportionately above kind of that threshold of who's experiencing that. And if we think about, again, that slide I just showed about how ACEs are associated with these poor health outcomes across the life course, that leaves these Black and brown kids to be disproportionately at risk for these negative health outcomes that follow. So if we circle back to this original ACE model, we find that Black youth are not only disproportionately likely to experience ACEs, they are also likely then to disproportionately experience the suboptimal neurodevelopment outcomes, social, emotional, and cognitive outcomes, health risk outcomes, social problems, and eventually early death outcomes, disproportionately above and beyond that of their other racial and ethnic peers. So the question is why? What is it that we're missing here? So first, we know that the traditional ACEs framework may overlook unique culturally relevant social determinants of health, such as racism. We also know that if we look at childhood adversity literature, there's actually not a lot of work being done that's looking at racism as a form of childhood adversity. But rather, what we have is these two separate tracks. We have racism work saying racism is bad for health, it's associated with poor mental health outcomes, physical health outcomes, physiological, cardiovascular, et cetera. Then we have adversity literature saying the same thing, but they're not talking about kind of in an interrelated fashion, but rather as two distinct forms of research. Yet, if we look at literature that talks about how racism cuts across virtually every aspect of the lived experiences of Black youth and families, one begs the question of why we're not talking about this, why we're not talking about these as interrelated entities, right? Racism plays a role at virtually every aspect of the lived experiences of Black communities to create, sustain, and exacerbate health disparities. As an example, decades of research has highlighted that the interpersonal expression of racism can predict negative mental health outcomes such as depression, anxiety, and traumatic stress across development and even intergenerationally. Yet, as depicted within this graphic, the scope of racism extends well beyond person-mediated expressions, so racial discrimination, and can operate through structural and institutional means to drive social and economic inequities that ultimately inform who's most at risk for these adverse childhood experiences. Right? This image is certainly complex, and there's no way I'm going to be able to highlight each and every one of these domains. However, I can highlight a few, right? So the systemic limitation of economic stability, right, through unequal hiring practices can limit the accumulation of wealth over generations. This is particularly important to note within our current society, as Black individuals have been found to hold more essential worker positions, thereby increasing risk for COVID, stress, mortality, leaving families to be less likely to have two incomes, thereby limiting the economic ability to gain wealth. In addition, we know that redlining and gentrification practices disparately place communities of color within impoverished neighborhoods where air quality is poor, healthy and affordable food is limited, schools are under-resourced and underfunded, thereby again positioning youth to be more likely to be exposed to traumatic experiences. Again, due to these practices, Black communities are disparately exposed and at risk for these ACEs that are conventionally measured in the literature, which are further compounded by experiences of racial discrimination that permeate their day-to-day lived experiences, whether that be being murdered by the hands of police officers, community members, unfairly stopped, unfairly sentenced. These practices disproportionately place these communities to be at higher risk. And despite these issues, Black families remain significantly less likely to be insured, thus limiting their access to mental health and other healthcare services. And even when they do receive these healthcare services, research has shown that the quality of care that they receive is poor. So together, these inequities uniquely and collectively position Black youth and communities to be particularly vulnerable, not only to adverse childhood experiences, but the effects and consequences of those experiences as well. So that's just racism broadly, right, as a system that we're talking about. But what about these discrete examples of racial discrimination, right? We know that racial discrimination affects youth literally from the cradle, from birth to their death. In fact, there's literature to suggest that well before they are born, while they are still in their mom's belly, mom's experience as a child are affecting how they are being developed within during pregnancy. We also find that after birth, Black adolescents are experiencing racial discrimination at a higher rate relative to any other racial and ethnic group, with the recent research suggesting that on average, when we think about online experiences, in-person experiences, vicarious experiences, they're continuing with these experiences on average of 5 times per day. And this is alarming when we think about the effects associated with discrimination, as we find that these experiences deplete cognitive resources, they get under the skin to activate physiological stress responses that over time can further erode one's mental and physical health. So given the noxious impact of racial discrimination, scholars have begun really recognizing that these racial stressors, not only discrimination, these discrete incidences, but kind of the system that we live in, represents more than just innocuous stressors. right? But it actually can rise to the level of a traumatic event. As defined by Robert Carter, racism-related stress and trauma can be defined as the emotional and psychological response to racial incidents that are unexpected, experienced as threatening, and result in significant psychological distress. And when we examine discrimination through this lens, what we find is that the consequences of these experiences considerably overlap with that of post-traumatic stress sequelae. So we have things such as alterations in mood, re-experiencing the event, rumination, hypervigilance, and even avoidance. Such evidence has led scholars to take a developmental approach to understand the impact of racial trauma. Perhaps not surprisingly, this work suggests that early experiences can negatively impact health and set the stage for suboptimal functioning. Sound familiar? So given this growing research base supporting the relevance of racial trauma, it's perhaps not surprising that we have these leading entities now recognizing that racial discrimination represents a significant source of stress in the lives of racial and ethnic minority children. So considering that we now have these leading forces in trauma suggesting, hey, maybe we should start thinking about this within the context of traumatic stress, it's perhaps not surprising that scholars have now started to say, maybe we should start thinking about this within the context of childhood adversity as well. To this end, what we find is that there's this movement to now think about how we can inform the adverse childhood experiences framework through this culturally informed lens. The problem is there's not necessarily agreement on the best way to do so. So some say that, hey, we have this conventional set of adverse childhood experiences, and we need to layer on top of that adverse community environments, right? Where we're thinking about other things that may inform it, but we still need to only be paying attention to these adverse childhood experiences when we're talking about adversity. But we need to also, think about what's happening in the background. Other folks say, well, maybe that's not quite right. Maybe we need to think about our conventional ACEs, but then expand how we also think about other ACEs, right? So if we're looking at ACEs, yes, we need to consider these definite ones. And then if you want to, you could also think about these if they fit the population that you're looking at. So it's kind of like let's figure out how we choose the best thing that fits to our study, but there's no real agreement right now as to the best way to do it, right? Said differently, there's a growing awareness and acknowledgement that there might be other ACEs that exist that are important to consider, but there's little disagreement as to how to do so, right? While there are certainly pros to this approach, I argue that there's a shared limitation here, and that they're not thinking about what qualifies as an adverse childhood experience. Typically, when we see this pyramid, we start here with this adverse childhood experiences and work our way up. But this was the original pyramid that was proposed. And what I mean here is that we need to be focusing on the bottom of the pyramid first before we work our way up. Said differently, we need to focus on the factors that precede adverse childhood experiences to really understand how we conceptualize adverse childhood experiences. We need to understand the key factors that inform and ultimately dictate who's most at risk for these experiences. To this end, I have recently kind of built on this model to figure out how we can best do this. So again, if y'all were with me a couple of years ago when I talked about this culturally informed model, here's kind of the final product that we've put out. So I've put forth a culturally informed conceptual model that positions racial discrimination as an ACE, but also as a something that's setting the stage for adversity, something that is an adverse experience by itself, and also something that predisposes folks for poor health outcomes that follow. So let me unpack this for a second, right? So briefly, this model highlights that racism operates in three simultaneous yet distinct ways to adversely impact ACEs, which maps on, to this pyramid, suggesting that it operates as a social condition, as an ACE, and also as something that can set the stage for things that follow. So what you'll see is I say first, racism operates as a systemic influence that increases risk for the vulnerability to other ACEs through the intergenerational transmission of racism-related stress, through disparate social conditions, and compromised biopsychological states. So let me unpack this for a second. What do I mean when I'm talking about historical trauma, right? So first, historical trauma is this collective traumatic experience from one generation that can be passed down to other generations. What we know is that experiences of discrimination can be passed down, the effects of that, through other generations. As I said before, it can increase blood pressure during pregnancy, which can also then influence how the baby is born and the baby's health after that. Perhaps not surprising that we see that Black mothers are more likely to have fatal births than that of white mothers, which has been directly linked to discriminatory experiences. Said differently, as youth are born, we have to think about the experiences of their ancestors. As without it, we're not thinking about the broader environment and social conditions that one is put in. When I say social conditions, what am I talking about here? Well, it's difficult to ignore the myriad of issues that systematically disenfranchise Black youth, increasing risk for mental and behavioral concerns across development. For example, we know that they're embedded within impoverished communities at almost twice the national average. We know that they're disciplined and suspended at school almost 50% higher than that of their white peers and overrepresented within the criminal legal system. We also know they're disproportionately attacked, violated, and victimized by police and community members, either in person, online, and through social media. And then we also have to contend with this psychosocial, cultural experience of white supremacy that has now almost become more obvious or more pertinent or blatant within our community. Indeed, these issues hold significance across our nation, including within North Carolina, which has declared racism to be a public health crisis. Thus, within this model, I argue that adverse social conditions shaped by historical and institutional racism also serve to uniquely amplify and affect youth's pre-existing biopsychological conditions informed by the intergenerational transmission of racism. So after we've talked about the things that have set the stage for adversity, I also propose that racism can function as a unique ACE that can independently and discreetly affect health while also compounding the effects of other adverse childhood experiences. So, for example, we know that racial discrimination can serve as a potentially traumatic event. We also know that these experiences don't only occur in isolation, but can accumulate over time through direct, vicarious, and virtual experiences. We know that these experiences not only affect health in the moment, but also have lasting consequences that last well beyond when the event happened. In fact, there's some literature to suggest that experiences that youth have in 6th grade can still be detected, kind of the negative health outcomes into the 20s as youth are transitioning into adulthood. We also know, though, that discrimination doesn't happen in a vacuum, meaning these events don't happen while nothing else is happening, but oftentimes they happen on top of other experiences, such that they can exacerbate the effects of other adverse childhood experiences. So in addition to serving as a unique ACE, I also propose that racism operates as a unique form of stress proliferation that increases risk following ACEs for negative health outcomes, given the disparities we see across healthcare domains and the inadequate resources we have to help youth adjust from racial discrimination experiences. Said differently, racism operates across the ACEs pyramid, and thinking about it in only one space is insufficient. We have to think about the holistic impact to really highlight the ways in which racism unfairly burdens communities of color to make them more at risk and more affected by these experiences. So this was the theory. This is something that I've kind of built off of and have been working on for a little bit, but theory without data is just an idea. So the next thing I was really interested in looking at was, well, what happens when we look at discrimination as a risk factor for other ACEs? And what happens when we look at the unique effect of racial discrimination on mental health outcomes if we control from other ACEs, right? If we take in the other ACEs into account, does discrimination still continue to predict negative health outcomes? So to answer this question, I was really interested in understanding, right? As I said, does discrimination predict internalizing concerns above and beyond other adverse childhood experiences? And does discrimination predict other ACEs, the co-occurrence? So this is just some background from the study. For the interest of time, I'll skip past that. But I do want to just tell us about how I approached this, right? So using a large nationally available data set, the National Survey of Children's Health, what I did with some of my colleagues, actually, Paul Lanier, who's a social worker here at UNC, was one of those people who's a fantastic collaborator. We're looking at Black youth within this national study, right? So we have about roughly 6,000 youth, half were male, and about 11 years old. What we're doing is looking at we're looking at parent-reported childhood experiences of adverse childhood experiences. So parents are asked, has their child experienced an adverse childhood experience? And they go down and say yes or no to different ones. They also do the same thing for discrimination. Has your child experienced discrimination? Yes or no? And then also, kids are experiencing discrimination. I highlight this to say this is one of the inherent limitations of talking about childhood experiences of discrimination with parents. Many times what we know is parents aren't aware of the ways in which children are experiencing discrimination, and children also aren't communicating the ways in which they're experiencing discrimination to their caregivers. So there's a bit of a disconnect. But regardless of those low percentages, what we find is that parents reporting that their child had experienced discrimination were significantly more likely to say that their child had experienced other ACEs, multiple ACEs, and childhood mental health concerns. Suggested there's something going on about these experiences that increases the likelihood that they're more at risk for the co-occurrence of other ACEs, multiple ACEs, and mental health concerns. So then the second question is, okay, we know now that there's some relationship, some co-occurrence between these experiences. So what happens if we control for these experiences? What happens if we filter out the unique experiences, the unique impact of discrimination on mental health? What does that look like? And even after controlling for these experiences, what we find is that the effect size of racial discrimination is comparable or greater than that of other ACEs in predicting depression and anxiety. This is quite scary, especially when looking at the comparable effects of racial discrimination to that of being physically assaulted by an adult or witnessing community violence. Let's pause for a second. As clinicians, what do we do if a child or even if an adult came in and said, hey, I was hit by so-and-so. Hey, I saw something happen in my community that makes me feel a little uneasy. Hey, there was some gun violence in my community. Think about the different ways that we respond, the different checks and balances that we have to support those children, the different people we can call, the different resources that we can rely on, the different strategies that we use. But what do we do when a child says they've been discriminated against? What practices do we have? What resources do we have in place? Who do we call? How are we serving that family? How do we intervene against the system, the environment, the space where these experiences happened? These results have really compelled me to question, what do we do or not do in the face of adversity within clinical settings? Isn't it interesting here that most of the adverse childhood experiences that we have some sort of evidence-based intervention, yet racial discrimination, which is evidencing similar, if not greater impacts on depression and anxiety, still don't really have any evidence-based treatments? We're not really trained to talk about discrimination in our clinical context. We don't really screen for it most of the time. What does this say about how we're holding culturally relevant forms of adversity relative to other conventional forms of trauma? What does that say about how we are serving those families who are coming in with these experiences? And how do we as clinicians even open the door to talk about those? Oftentimes within our multiculturalism course or courses, we talk about it maybe once or twice, but we're not really given the skills to have these conversations, to navigate those spaces. I often ask, how many classes as a 5th year or 6th year student have you taken on stats or on psychopathology? Most would say 2 or more. How many courses do we have on multiculturalism? How many courses do we have on bringing topics into the clinical context that we may not be familiar with? Yet our APA guidelines suggest that we need to have expertise in multiculturalism. And we have data, years of data, suggesting that discrimination represents a significant impact, a significant stressor, a significant detriment to the health of these communities. Yet we're not really doing much. These collective findings have really kind of have unsettled me and have really motivated me to continue this work. And have really helped me to understand, right, like how and why it's important to ask these questions. Unfortunately, there's not a lot of work being done here to assess ACEs on a broad national level. So we have the behavioral risk factor analysis that's done by the CDC on a yearly basis. But in North Carolina, they actually stopped measuring ACEs in 2014. And they have not ever included experiences of racial discrimination within that. So that analysis of 50% of youth experiencing ACEs may actually be an underestimation of how many youth may be experiencing this, especially when considering that discrimination was never measured in the first place. So as a clinician, I've really been led to understand, okay, so if we know that discrimination is bad for health, why? What can we do and where do we intervene, right? So one kind of new novel aim of my research has really been to understand that piece. Where and why? Why is discrimination bad for health and how do we stop it, right? So some recent work that I've put out has looked at this question exactly, this understanding, okay, what are the pathways by which discrimination may impact health? One area in particular that I'm really interested in, this idea of rumination. As a trauma-related outcome, what we know is that after a traumatic event has happened, individuals tend to replay that event over and over in their head to make sense of it, or replay the negative feelings that they're having. And what we find is that rumination continues to be a pretty robust pathway by which racial discrimination impacts depressive symptoms, not only among adults, but as youth as well. And some emerging work that I have found is that this pathway becomes stronger as youth get older, suggesting that if we can help disrupt the ways in which folks are thinking about these events, we might be able to disrupt the negative consequences that follow. So as clinicians, it's really important to think about how and why these things happen and how we can unpack that. So I'm really excited to have some funding to be able to answer some questions like this over the next few years. And that's one big area that I see my research going. I'm very excited to answer those questions. That being said, I don't want to end on doom and gloom, right? I think it's important to recognize that the ACE framework is centered on risk. Yet, what we continue to see is that Black youth are evidencing important patterns of resiliency in the face of adversity. That is, we generally find Black individuals to report lower levels of mental health concerns relative to their white counterparts, while also reporting higher levels of flourishing, or a common marker of behavioral and social well-being. And while there are certainly exceptions to this finding, this general research trend speaks to the inherent resilience of Black youth and suggests that there are underlying protective factors that may promote wellness in the face of social inequity that we need to be paying attention to. Thus, I want to be sure to acknowledge the importance of considering heterogeneity, particularly within the Black community, and the protective or promotive factors that can disrupt the link between racism-related adversity and health outcomes. Those can include things such as racial socialization, or how parents and families are having conversations with their kids about race, social support, who one has around their environment, racial identity or the significance and meaning that one places in their race. There are many different factors that can feed into this resilience. So it's important not to only think, well, there's a person of color sitting in front of me in the clinical context, they're doom and gloom, I need to be thinking about this, but rather think about them as a person, right? The absence of risk does not mean the presence of resilience, and the presence of resilience does not mean the absence of risk. These represent two very different things that can be thought about together. So in conclusion, to reduce the health effects of racism and other youth experiencing marginalization, it's critical that we validate the perceptions and experiences, empower them, and collaborate them to leverage the community strengths they identify. In doing this, we can learn how to disrupt adversity, normalize what adversity means, and also move forward with this literature and with these practices to help promote strengths and resilience over time. So with that, I want to thank you all so much for listening. If you want to contact me, feel free to reach out. I'm always happy to have conversations. But what I'm most interested in is for the Q&A to follow. So thank you all.